That's right, I'm at a district health board and I'm a general paediatrician, and part of my interest in allergy and immunology is one of the focal points for what we're going to be talking about today, which is that there was a time when this was seen as very much a specialist tertiary hospital speciality, and those days are gone. This is now bread and butter paediatrics. It should be bread and butter primary care as well. And like it or not, it's coming our way. So that we have to have skills about how to interpret allergy testing, how to take an allergy history, how to think, and also how to use some very simple but special equipment, some of which we'll go through, and you might even have seen some of it on the desks already. So we're going to do this as a workshop and have a number of illustrative cases, and then if we need to, there's a little sort of more formalized talk towards the end of it about anaphylaxis as well. But before we move on to the talk itself, I'm going to let Shannon introduce herself too.
Hi, so I'm Shannon Brothers, Paediatric Immunology Allergy Specialist at Starship Hospital. Look, there are two part-time paediatric immunologist allergists in the country, and so Simon's absolutely right. We have a food allergy epidemic. There's been a massive increase in food allergy, food sensitization, and working with general paediatricians where this is their special area of interest is crucial, and also working with general practice, public health nurses, nurse specialists. It really helps us with our workload, which is ever increasing. We just simply can't see everyone. We use a different model to in Australia, where everyone is seen by paediatric allergist immunologists with food allergy. But I think our model works really well. There's a Paediatric Society special interest group for those who are paediatric nurse specialists or have an interest. And there's a GP, I've forgotten the name of it momentarily, sorry, but special interest group in food allergy and allergy in general, so those are worth considering. We're going to tag team.
And again, we do want this to be interactive, so there is nobody in this room who does not have a useful opinion or thought on this, and you're going to be seeing it. You're going to be seeing it on a daily, if not more than daily basis in the future. So the approach that we're going to do is that we're going to have some interactive cases. We can take as long or as short as we like on individual cases, and we'll stop to get your feedback, get your personal experiences. You can have a chat with some people on either side of you as well, and each time we put a slide up, you'll have a little bit of time to have a little think about what we're after. And feel free to share your thoughts, but obviously don't take things over. We don't want a 20-minute lecture in the middle of our lecture. And we'll be looking at a range of paediatric allergy-related topics. So again, neither of us deal with big people, we deal with small ones. So there will be some burning adult allergy issues, but we're probably not the best people to ask about those. And it might be handy to have a pen and a piece of paper, but this is your talk, so interact.
And conferring with people on either side is a good idea. Specialists don't always agree with each other, so you guys might not always completely agree with each other.
And I think that reinforces another thing as well, that a lot of what we think we know and a lot of what we teach, I think anybody in the allergy business is prepared to admit there's a lot of art rather than science goes on here. And there's a lot of conceptions and misconceptions out in the general public as well. Just as a straw poll, put your hand up if you've seen anaphylaxis. Okay, I gave a talk a few years ago to a group of public health nurses, and there was probably about 60 people in the room, and I swear 55 of them put their hands up. Now, they could not statistically have all seen anaphylaxis. They may have seen things which they thought was anaphylaxis, but this has quite a big difference to your practice if you're overcalling or undercalling anaphylaxis. So some of the time will be spent on what is anaphylaxis, how would you define it, what would you do if it happened in front of you? And there's a little practical element to that session. So first of all, we're confirming that we don't have any conflict of interest. In fact, I did, because since Karen is my wife, if I hadn't volunteered to do this, I would have been in big trouble. So that was my conflict of interest. And there's a lot of information out there, and we'll be highlighting some good sites to get this information. It's all free, and it's really, really good and concise and useful. So you need to know how to access those as well. So let's start off with something you could see any day of the week. So, what clinical description best describes this appearance? Now, you might not be able to see that very well, so I'll tell you that this is intensely itchy. It's come up quickly. You can see that there are raised areas which look slightly paler, but they're surrounded by a red flare as well. And this child is itch, 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 and these things are coming up all over the place. So, who wants to tell us what this is? Yeah, it's urticaria. You see this every day of the week. Other names for urticaria? Yeah, or yeah. And how would you describe, what would you say they were? What word would you write in your notes? How would you describe these? Yeah, particular word in mind? A lot of people would call these wheals. Never been able to figure out if it's wheals with a H or wheals with without a H. But these are intensely itchy. So this is urticaria. Statistically, what's the most likely underlying cause in an otherwise well non-atopic child, especially if this rash has been there for more than 8 hours? Because we see lots of these cases who get referred to us quite often through an emergency department as well. And the commonest cause is common viral infections. But you see that rash and people immediately think this must be an allergy. And 80% of children with rashes that fulfill these criteria, it is not an allergy. But if you're not careful, it's open to misdiagnosis. So again, we see this every week at the emergency department that I would be dealing with. So not everything that's raised and itchy is due to an allergy. And I think that's lesson number one, is that other things than allergy causes itchy rashes. Shannon, any comments on that?
Can I just reflect on that? Describing the rash, absolutely crucial, because the number of times nurses are way better at this than doctors. I have to tell you, the number of times doctors in a hospital setting will write allergic rash, and it's not helpful. So Simon's absolutely right, describing the rash and temporal relationship to anything is really useful.
I think, again, knowing sort of the background of spotting the sick child and spotting rashes and other sources of information as well, putting it into words makes a big difference. It's not sufficient to just say rash or allergic-looking rash. And of course, a lot of these kids are not well because they've got their virus infection. They go along to see a primary care practitioner and they get given an antibiotic for good or for bad reasons. And then this rash progresses, and those kids get labelled as being allergic to the drug that they were on in the first place. But they didn't start off with the rash. They went to the GP because they were unwell. But if you're not careful, that child is then labelled for the next 80 odd years of his life as being allergic to a drug. And again, it's all down to the history. Let's progress to a few other things. Here's a graph, and it's showing an increase in cases for food-related anaphylaxis. Let's just stop there. Somebody brave, please put your hand up and give me at least one definition for anaphylaxis.
Respiratory symptoms.
Okay, but so does asthma, so does pneumonia. So what else apart from respiratory system? So you're sitting in your clinics or your clinic room, whatever, and a student who's with you says, what's the definition of anaphylaxis? What are you going to say? Okay, I think life-threatening is a good way to put it, and in fact some older textbooks call it a fatal or near-fatal, overwhelming, systemic allergic reaction. There's lots of definitions out there, but it implies that you are involving more than one system, and that commonly invokes either respiratory or cardiac or both, and that it is life-threatening. It's in a different league to somebody who's just a bit itchy for another reason. So that's anaphylaxis. These are rises in cases. Look at the time scale over here, but look at the slopes on those. What do you think A is? What do you think food? What food stuff is causing that? Top of the list. Okay. Look at this, 328%. These are real cases. This is not sort of might be, might not be. I can't think of another group of illnesses that have shown rises like this in that time scale. And this is real, and as Shannon said, we are dealing with an epidemic of true blue food allergy and anaphylaxis. This isn't imagined, this is real. And this is why no tertiary specialists unit can ever deal with these numbers. And look at the other things as well. They're all going up, but it's peanuts that are way out in front there. So this is, I think, Australian data, but it is reflected in our practice. I remember back in the UK, we used to perhaps have 50 new referrals a year for allergy of some sort or other. And within about 5 to 8 years, that had gone up to 500 referrals. And that's either because we're better at picking them up or because it's genuinely showing an increase. And if you're going to ask me why, I would say, I don't know, but it's real. All right, let's give you some little cases. Whilst on holiday, a 3-year-old boy has a sudden onset of increased work of breathing. So he's breathing fast, he's putting more effort into breathing, he's using accessory muscles, he's recessing. After eating a chocolate biscuit, about 10 minutes later, he also developed a widespread urticarial rash, and they come to you, they've been on holiday, so that settles down. He comes to see you the following week in a clinic or a school setting. And you know that this is a boy who has asthma. He's had 3 admissions. He's actually quite unstable with his chest. So what are you going to do? There's your choices. This is something you guys must be seeing really quite frequently. So what are you going to do with this boy? He's in front of you now. You've got to do something. Okay, so the options are you going to recommend he gets an adrenaline auto-injector? Where'd you get those from? So let's say you said yes to that. How are you going to go out getting one? Okay, so we've had one opinion that that's a paediatrician's role.
Or doctor would refer them.
All right, okay. Refer to your local allergy service. First of all, how many of you have a local allergy service? Because unless you live in Christchurch, Wellington, or Auckland, I think that's probably right. There aren't any other tertiary specialists in allergy. So you're not going to have a local allergy service. You'll have a local general paediatric service. But as we know, and as I'm the first to admit, the degree of expertise within those units is incredibly variable. And, you know, many paediatricians are just as nervous about dealing with allergy kids as everybody else, because it's scary stuff and we don't know really what we're doing sometimes. Would you say, no, I'm not just going to give you a prescription or send you off or go get you to see somebody else. I'm going to teach you how to use an adrenaline auto-injector. When I'm saying adrenaline auto-injector, for the purpose of this, can we just call that an EpiPen? Because, as you know, there were other sort of forms available, and if you travel the world, there are other forms, but this is what we have in New Zealand. Or all of the above. If you refer to your general paediatric service or allergy service, how long do you think it's going to be before he gets seen? 6 months. If it's a tertiary service like Starship and some other units, they do try and see children really quite quickly. What's the child got? What are you going to write on the notes when it says diagnosis or impression? What are you going to call this? He's had a rapid onset reaction with a rash, but his breathing was affected as well, and you know he's already got a background of asthma. So what word are you going to use? And anaphylaxis. This child has had breathing difficulties in the context of eating something that's provoked an allergic reaction. And I think, again, I'll hand over to Shannon for her personal experience here, but they were actually afraid of using the word. you're at anaphylaxis. That means you've got to do something about that. And you have to take a course of action. And the number of referrals we see that come to paediatric units saying allergic reaction with a bit of wheeze, allergic reaction and felt faint, allergic reaction with scratchy feeling in his throat. And you want to beg people to say, it's anaphylaxis. If it walks like a duck and it talks like a duck and it quacks like a duck, it's a duck. But if you don't use the right word, you may be given the wrong message. Is that your experience too?
Oh, absolutely. And look, we see this less lately, but about 5 years ago, we used to see children referred in who had angioedema urticaria treated with adrenaline, and yet the child, and clearly that's not anaphylaxis, and yet the child who had urticaria and wheeze wasn't called anaphylaxis. And I absolutely agree. Multi-system involvement with respiratory or cardiovascular involvement, that's anaphylaxis.
So I think my response to this question,
I don't know if Dr. Jefferies is allowed to ask a question.
What's the worst thing to do? Give another chocolate biscuit and see what happens?
Take a history and find out what the ingredients were.
Give a chocolate biscuit, he's fine, don't worry about it.
Yeah, but I think if you were doing that, you would also be,
What's the worst thing to do?
you'd also be checking your medical defence subscriptions. I think. Yeah. But again, we'll come to this later on. You would take a good history.
Is your wife allowed to ask a question?
Am I allowed to ask a question? So the fact that he's got a history of asthma, that amplifies the degree of urgency around this, doesn't it?
Well, the degree of urgency is there regardless. If he hadn't had anaphylaxis and he was peanut allergic at school age and he has comorbid asthma, that increases the risk of a more severe reaction on next exposure. You'd want the asthma well controlled. You'd want that person to also have an adrenaline auto-injector.
So I think that's an important practice point as well, that poorly controlled asthma ups the ante. So again, this is a red flag. If you've got a child with an allergic reaction and poorly controlled asthma, you should be thinking the next step up the ladder. So we'd say all of the above, but also don't forget an anaphylaxis management plan. Now you've got some examples of those. There are lots of them around, but the one we like most is the ascii one, and the one that's easiest to access. So this is free. Do you know what ascii is? The Australasian Society for Clinical Immunology and Allergy. And it's a big business these days, but they have easily accessed websites. They are an absolute goldmine of information. If you want to know anything about allergy, if you'd like to do a course, a little online course about allergy management, if you'd like allergy management plans for children who need an EpiPen and for children who don't need an EpiPen, travel plans, things like that, all easily and freely available. So absolute goldmine, and I'd strongly recommend that you have it saved on your desktop.
In addition to which they have an e-learning anaphylaxis online course, which takes, 20 minutes, maybe longer, maybe an hour. That is definitely worth doing for CPD points thrown in.
And I've done that recently, and it is really good. It is really good. The other thing is, it's one thing prescribing it, and that might be done through your GP or through a colleague or whatever. But again, it's no point giving people these and they say, well, what do I do with it? How do I use this? So hand on heart, honestly, how many of you now would know how to show somebody else how to use an EpiPen? Or if it happened right in front of you, would you be first up to jump and say, I have this EpiPen, I'm a good practitioner, I know what to do and I know how to do it? So hands up. Good, but also good to see people not putting their hands up, because I think that implies that, that's the usefulness of this session. So we'll come back to that in a second. Again, it's not just the parents and the medical carers who need to know about this. Children go to school, children have babysitters, children go to kindy. And when you think about it, if you're at school or at kindy, you might be spending 6 to 8 hours a day in the care of somebody else who probably needs to know what's going on. And that's in itself been something that we've all seen a sea change in over the last few years about the number of, or the success of liaison with schools and with kindies in particular. I remember in the UK, children being denied the ability to go to schools if they had an allergy, because the teachers would just say, we can't deal with this, we're not doctors, we're not nurses, it's in the too hard to deal with bag. And thankfully my experience in New Zealand is very different to that most schools now are very open to that. The public health nurses often will go in and teach the use of adrenaline in those circumstances. There's good liaison. It can always be better, but it's actually not bad at all. And the other thing is that asthma control needs to be improved as much as is feasible. These are the ascii recommendations for primary care. So this is primary care. This is not hospital-based. This is not tertiary-based. This is what they think primary care physicians or primary care practitioners should be doing. I wonder if you read that, how many of you would feel capable of doing that? And again, is this a clarion call that at the end of this talk, you'll be doing a little bit of reading and putting yourself in that position? So be educated about how to reduce the risk. Be educated about the early signs and symptoms, know what to do in an emergency, have an ascii management plan completed by the practitioner, and carry an adrenaline auto-injector and know how to use it. And again, I'm not going to ask for a show of hands, but how many of us are actually in a position to do that? Whether we're hospital-based paediatricians, public health nurses, specialist nurses, nurse practitioners, GPs, I don't know, but you will. Just so as you know, and I'm not going to show you in great detail, but these are the action plans for anaphylaxis. So there's like a personalised one, and there's a more generic one. I'm going to skip over that for the second.
Sorry,
that's what they look like.
Sorry to interrupt you, Simon, but there've been new changes made to that one, but the wording's pretty similar.
Yeah, they're in nice colours. It's red if you're anaphylaxis. It's green for the non-anaphylactic reactions. But there's room for a photograph. You put the personal details of your child there. Many parents get multiple photostats, and they have one on the fridge, but they also have one for the babysitter, and they have one for the kindy and stuff like that, and they put a few contact details down there. But more to the point, it actually says on them about what to look for in anaphylaxis and when you'd be suspicious of it. So can you sneakily put those back down again, because now on each table there should be at least one EpiPen trainer.
Hopefully more than one.
So these are trainers. You're not going to inject yourself accidentally, although I did have a father who did do that, thinking it was a trainer, and it wasn't, and he injected his own thumb. And he said for a while there it went a bit pale and a bit cold, and then it wore off. So again, just emphasising a point that we always hammer home as well, that if there's a reasonable doubt about whether you should or shouldn't give an EpiPen for somebody who is known to have anaphylaxis, the chances of you causing harm to that child, so again paediatric patients, is very, very small indeed. That's different if you're 80 with multi-system disease and 5 different heart medicines and it's injected intravenously. And there have been deaths doing things like that. But of course, that's not what we would recommend. So again, please will you have a look at those EpiPen trainers. Again, if anybody's feeling brave, could they pretend that we've never seen one, we don't know, we're some parents. How would you describe to a parent about how to use it? Just spend a couple of minutes looking at those. Okay, I think that's long enough to at least have a feel for whether you're completely ignorant of this or whether it's a revision process. One of the things we've just learned, though, is first of all, you've got to be able to read English. Secondly, you've got to have your glasses on to be able to read it. And thirdly, you actually need to know it's written on the machine itself. And also, of course, on the allergy management plans. It's actually quite clearly delineated there. Again, this is what they look like. They do change occasionally from time to time. You'll be aware that there's a junior one, which we tend to use up to about 20 kilos or so. Once children are above that, we tend to use the adult one for all ages. So again, just make sure that somebody does actually have the right strength of EpiPen. Giving it says this on the bar, on the trainer itself. So you make a fist. You pull off the blue safety release, yeah,
Okay,
which I
okay.
saw some people not realizing. You put the orange end against the outer thigh, and it says with or without clothing. So again, if you've got a sort of fairly anxious teenager who doesn't particularly like you ripping their jeans or shorts or whatever off, do it through the clothing. It does have to be reasonably thin clothing. You won't get it through heavy denim or ski gear and that kind of thing.
Or pockets.
Or what, sorry?
Or pockets.
No. And you place it there and then you push down, and there's quite a decent click when it goes. Somebody's just done it, yeah. One of the ways, was it you? Yeah. And again, just as a couple of little comments, one of which I learned from one of my patients who was about 10, who said this is how she remembers it. But she says, blue to the sky, orange to the thigh. And the other thing is, we had a boy who was terribly nervous about doing this. He'd never needed to, but just the very thought of it, because he thought what you had to do is get the needle and then wallop it in. And again, it doesn't say that, it says place. So again, it's not a swing and stab, it's a place and push. And kids do get anxious about this. The other question I often ask parents as well is, if your child really needed it, would you have any hesitation in doing it? And quite a few people do say, I'd be really anxious about doing this. I'm not sure I could do it to my own child. To which my response is, trust me, if you were in that position, you will do it. And again, there is a psychology to this. It's a fairly unique medicine, isn't it? What other medicine can you carry around with you for 10 years and never use? What other medicine costs you $130 or so every year or so, and you replace it, but might never use it? And what other circumstances do children or adults inject themselves or each other with a device like this, notwithstanding diabetes?
I was said Viagra, but then the injectable question came up.
Oh, right, okay, yeah.
And she chuckled.
Yeah. As in a medicine you carry around with you for 10 years, but you never need to use. Yeah, okay. No, I'm not even going to go there. Yeah.
You're on camera.
Yeah. Yeah, we might well have to edit some of this out a bit later on. So, again, I'm not expecting you to suddenly be EpiPen experts, but do people at least feel that this is learnable? It takes you 5 or 10 minutes to learn how to do that, and it's doable.
Can I just also say, really important, once you've heard that click, to hold it there for 10 seconds. Otherwise, you pull it out and you've got adrenaline all over the floor. So
And
it's
there's
easy.
great gelatin and animal models showing how it isn't an instantaneous injection, it does flood in over time, so you do have to hold it in for that 10 seconds. I've done it on myself, not with adrenaline, but it really doesn't hurt. It doesn't, really isn't a painful procedure at all.
The other thing to remember is, because I saw a few people doing this, the thumb does nothing with an EpiPen. There was confusion created when Anapen was on the market previously. And unfortunately, we no longer have a competitor, but it's really important to remember that clicking there is not going to do anything.
Yeah, Anapen was a strange sort of thing because it was never designed to deliver adrenaline. It was actually a subcutaneous insulin sort of machine, and the needle size probably wasn't long enough, the injection depth probably wasn't long enough, so it's sort of faded into obscurity now. I can't remember the last time I saw anybody with an Anapen.
Sorry, is there any clarity about, because we didn't really answer that question, about where you would obtain one? So at pharmacy, yes, but so you can get it through a pharmacy online, or you can get it through any pharmacy. I always tell parents to shop around. It really, really annoys me when people come in telling me they've had to pay $210 for one with a shelf life of 6 months. Shop around, it shouldn't be more than $135, $145 should have a shelf life at that point of about 12 to 15 months. Yep, allergypharmacy.co.nz online. I'm very good at keeping prices down.
Okay, let's progress. We want to move on to a few other things. What's been done here? What's the name given to the appearance highlighted, and some thoughts about the diagnostic information? I think that's quite difficult to make out. So a procedure has been done to the child, and you have a sort of response which looks like that. That's the outline of it. This is raised, it's pale, it's surrounded by a little bit of redness. What's been done? Yeah, so I don't know if anybody do your own skin prick tests or you see these. Probably not actually, because they're done under fairly sort of controlled circumstances in labs or in hospitals. But usually you get a roundish or oval reaction. This is quite ragged, and these are called Pseudopodia. So occasionally you'll get reports back for skin prick tests and it'll mention Pseudopodia, and the emphasis is that this is probably a more severe reaction. And also you've got some satellite lesions out on the side there as well. So we quite often see reports mentioning satellite lesions, Pseudopodia, but that's what positive skin prick tests look like. All right, what are these?
Peanuts.
Who said peanuts? Oh, okay. But he's digging them up.
Yeah.
Yeah, peanuts are not nuts. Peanuts grow in the ground. We lived in Africa for a few years and used to grow these, and you'd pull them up and they're on the end of a bush, and then you pound them in a pot to make peanut butter with no additives. And yeah, so this is one of the reasons that they're called another name. What's the other name? Yeah, they're called ground nuts, and sometimes monkey nuts as well. And I suppose that's the point I'm making here, is you do need to be careful that people understand that a peanut is a ground nut, is a monkey nut. And again, classic story of a granny who was looking after a child, knew the child was allergic to peanuts, sat there with a bowl of nuts, saying, these are assorted nuts. I know he's allergic to peanuts, so if I just sit here and pick out all the peanuts, then go ahead and help yourself. The other example is, the auntie who says, well, these are monkey nuts. He's all right with these. So you do have to be careful that people understand what you're talking about. But these are peanuts. What are they more related to? What are they closer to? Say again? Yeah. So again, they have several different names. And like I say, if you live in Africa and you're doing research, then what you do to make your own peanut butter as a food supplement is you stick them in there and you pound that stick up and down for the next 4 hours, and you end up with lovely smooth peanut paste at the end of it. Complete staple of diet for most children in West Africa, and of course you never see peanut allergy, which will take us on to something else. Now, something again you're going to be very familiar with. Both parents come to see you for a review of their 4-month-old son who has eczema. How many times do you see this? They want to know what are the chances of him having an underlying food allergy which contributes to his skin condition. Now again, we had a child with eczema, and I know that parents will do absolutely anything to try and get rid of their child's eczema. There's a desperation there. And of course, all of the medicines that we do is to try and make things better. It doesn't get rid of eczema. Time gets rid of eczema, we think, but that doesn't help you when it's 3 o'clock in the morning and your child's tearing their skin off. So they're already often looking for a culprit. If there was just a food or something we could remove so that the eczema would go away. So what are your thoughts? Because this must be something you get all the time. It doesn't even have to be in a clinical setting. It could be, people chatting around a barbecue.
I thought only for moderate to severe eczema there's a link with food allergies, and it's still not a high percentage.
All right, so hold that thought. That's a good thought. Yeah, any other thoughts, any other comments?
Probably not, because he's only 4 months old, so he's not on solids yet.
Oh, right, okay, and that leads on to another group of issues, which we'll come to in a little bit. Yeah. If this is a breastfed child, and his mum's asking, are you going to say, well, why don't you try cutting things out of your diet because it might make his eczema worse? Because that's a tough call to make, actually, saying to a mother, why don't you cut out nuts, egg, dairy? Dairy's hard. No yogurts, no milk in your coffee, no milk on your cereal. It's not an easy thing to do. Okay, Shannon, would you like to have some comments?
I think you will probably get to this in the next slide, Simon, but yes, this child hasn't had any solid foods yet. There are some tiny amounts of food allergens in breast milk, but I agree with Simon suggesting extensive exclusions from a maternal diet, or even one at a time if it's a very necessary food group, is hard for a breastfeeding mother with limited evidence. What I would do is optimise eczema care in this baby and then reevaluate. And yes, for the more moderate to severe eczema, there's a link in terms of comorbid conditions and probably sensitisation through skin in terms of food allergens.
So let's have some thoughts there then.
We may not agree.
Well, I think that's something we agree on, because again, this is something that people are looking for a magic bullet, and nothing is ever going to replace good eczema care, which I think is one of the biggest challenges we face, both as practitioners but also with our own kids. Putting creams on, doing all the right bathing and so on. It is hard work, especially if you're working yourself or you've got several kids or you've got twins with horrendous eczema. This is hard. And you wouldn't swap places with somebody with a child with severe eczema at all. But nothing is going to interfere or should interfere with good basic eczema care. We know that food allergy affects up to about 10% of children under the age, and again, so a good history of knowing what kind of eczema this is. Is it eczema for a start? Is there a strong family history? Are there other atopic diseases in that family? And we know that these are risk factors for food allergy. When I say atopy there, I'm meaning that conglomeration of conditions that include food allergies, eczema, hay fever, and asthma, which we talk about like they're separate diseases, but we know that they overlap to considerable extents. But are people aware of something called the allergic march? This idea that you may show evidence of eczema as a baby, but then that improves a little bit, but you start to get wheezy chests and asthma. And then that sort of starts to grow out, but then you start to get hay fever. The idea that there's all IgE atopic related disorders, but the way that you show them changes with age. So it's not compulsory that you do that, but it's actually a very commonly seen problem. Again, the severity and the age of onset. So eczema that comes on in children under the age of 3 months, I think you would be thinking much more in terms of other triggers that might be controllable.
Or comorbid food allergy.
But this is one of the things that actually is really quite important, because we see a lot of children who have been excluded for good reasons or whatever, but you see them and they're 7 and they're still egg-free, dairy-free, nut-free, this-free, that-free. And it's never been challenged, and some of these children are actually on a very compromised diet. So all the fun things have gone. Forget birthday parties and cake and McDonald's and stuff like that. Not that McDonald's is fun, but it's common. But these are children who are very restricted, and if you're not careful, your calcium, your vitamin intake, your iron intake can be severely compromised. Plus, if you're on a special diet, it costs. It costs you in time and it costs you in money. And again, I think if you withdraw a food or food group and that child marvelously gets better, then you're onto something. But if they don't, we have to be prepared to say, we've given you a decent chance. The eczema really hasn't improved over that chance. Therefore, we must reintroduce that food and go back to it. That would be my practical approach. Would you sort of
Absolutely.
concur with that?
Although I would be reluctant to suggest withdrawal of foods in this situation, and in fact this baby is not having any solids yet anyway.
Yeah.
And I still want to optimise eczema treatment, which goes back to Simon's first point. But yes, if somebody has withdrawn food, re-challenge, absolutely vital. And I think you need to think about why you're doing it, because withdrawing, losing tolerance may result in persistent food allergy later on. When the eczema is completely resolved, you're stuck with a long-term problem at that point.
And the bottom line is that, there's a lot of downsides to this, as we've mentioned, but eczema is a roller coaster disease. It goes up and it goes down, and sometimes it doesn't make sense as to why it's done that. And we just need to be careful that we don't overcall it in endlessly looking for an underlying trigger when actually that trigger might not exist. All right, what are these insects? Just stick with the 2 on the left. Do you not think the wasp in the middle just inherently looks evil? We sort of have a fondness for bumblebees. They bumble around. We like honeybees. You know, they look reasonably innocent. We know they can have a sting in the tail. But nobody likes wasps. Again, I'm not even sure what eats wasps. You know, what's the natural predator for wasps, apart from New Zealand kingfishers, which seem to like them. But I don't know of any other creature that deliberately targets wasps as prey. So, any Australians in the audience? What's this one?
Bull ant or red ant?
It is a ant, yeah, welcome. You mentioned bull ants, but this actually isn't a bull ant. We'll come down to that in a second. And which cases, most cases are anaphylaxis are due to which creature? Yeah, statistically that's correct. Although, you know, people often get stung by wasps, it's actually honeybees that are the most common. So it's honeybee that actually is responsible for most cases. And I don't see a lot of this, but I work on the North Shore, and there aren't too many people who actually have hives. But some of our colleagues, especially on sort of the north of the South Island, this is quite a big thing for them. These are often kids living on rural plots, and people do keep bees. And of course, if you're a beekeeper, being allergic to bees it's a bit of a bummer, because you're often out in the middle of nowhere when you get your stings.
And it's usually not the beekeepers that develop the allergy, it's usually their children who are stung infrequently.
People often say, what can you do to try and avoid stings by insects? And, you know, it's hard to think. But if you go to the ASCII website, they do make some very useful points. Don't wear brightly coloured clothes in summer. Yeah, that's okay, that's a bit hard to do, but especially floral patterns. Be careful of perfumes. Don't put your barbecue next to the bins. If you're drinking Coke on a picnic, have a look inside, because it's an old wasp trick, isn't it, to climb inside the drinks can. Then you take a drink, you've got a wasp in your mouth who doesn't like it and does what wasps do. That ant was the jack jumper ant, which we don't have a problem with here, but these are horrible, vicious things. They tend to live in parts of Australia, Tasmania, sort of the coast along New South Wales and Victoria and so on. It's a big issue there, but thankfully not one that we've got at the moment. That's a paper wasp, which again is rather more of a problem in Australia than it is in New Zealand. Okay, one of your mothers has a 4-month-old baby with some mild intermittent eczema. She's seen and read lots of conflicting advice about when and with what to introduce foods other than breast milk. In other words, weaning. What will you advise her? Would you do some tests prior to doing anything?
No.
So that's no to, would you do some tests? No. Okay. Right, what would you test to? I suppose would be my question, because you're just going to be doing this randomly, aren't you? And then what will you do with that information? So when are you going to tell her to introduce foods other than breast milk?
6 months.
All right, we've got 6 months. Any advance on 6 months?
Between 4 and 6.
Between 4 and 6. Yeah, which coincidentally is often around 4 to 6 months, isn't it? And again, it's one of those examples. If you actually just go back to nature and let the child tell you what's going on, they're quite often not far off the mark. Now, one of the points about this discussion is that ASCII is certainly recommending 4 to 6 months. That's a bit of a change from WHO recommendations in the past as well, which was more along the 6 months line. And one of the reasons for that is this idea that if you introduce foods too late, you run the risk of missing this magic hypothetical window for tolerance. But if you introduce foods too early, your immune system isn't ready to develop tolerance yet. And the idea that there's a little bit in the middle that's just right. And funnily enough, it happens to be when children are showing signs that they do want something other than breast milk. So, you know, surprise, surprise. And there's a whole host of things that make sort of some sense of that in terms of factors that influence the capability for tolerance. But when you think about it, you go from a baby who eats nothing in the womb to eats breast milk outside and then has to come across hundreds of different allergens in his diet, in his environment, and principally in his food. What's surprising is that any of them ever get it right. But there does seem to be this window of opportunity, this window of tolerance that you don't want to miss by being too early, but you certainly don't want to miss by being too late either. Shannon, any thoughts about the sort of window of tolerance and the bad effects of leaving it too late? Because that's what we've done in the past. We used to say to people, delay the introduction of this, that and the other. And we did it because that was the evidence we had at the time, and people thought they were saying the right things. But there's some evidence as to why that might not be the case.
So guidelines started to change in 2008 with a feel that that was the right thing to do in terms of earlier introduction. And Simon's about to present the evidence that came later.
Anybody know about the LEAP study? One of the reasons all of this came about is that there was an appreciation, and I mentioned this already, about how we really did not see children with peanut allergy when we worked in the Gambia. And there's a whole host of reasons why that might be. But a lot of Israeli families are brought up, babies included, are brought up on some of these snacks. And they're full of peanut and peanut butter. And there was the appreciation that these children, and it was also introduced really quite early, certainly within the first year of life, and there was an appreciation that these just didn't seem to show the same incidences of peanut allergy. So there was a sort of cultural model there, but it was a sort of stepping board for the LEAP study. So I've really cut this down in terms of presenting it, but this was 640 high-risk infants of 4 to 11 months. So high risk in terms of family history or in terms of other atopic diseases. And they were randomized either to receive or not receive peanut products for the first 5 years. Now, there were fairly rigorous screening to be done first. So again, a child who had a skin prick test done, I think it was more than 5 that they used as their cutoff. But basically, if you had a positive skin prick test, they didn't push you forward for this because their appreciation was that you probably were in a group where you stood a better chance of reacting, and that wasn't the point of the study. And look at those rates. So for the group where they were allowed to have peanut and peanut products over that period, there's a difference of about 17% versus 3% for developing food challenge proven peanut allergy. So they tested all these kids afterwards. So that's as good as we can get in terms of proving or disproving allergy. But look at the difference in the rates, and that amounts to a relative risk reduction of 80%. So you're onto something here. This is a game changer, and it's showing that actually that idea of introducing foods early, but not too early, to hit this window of tolerance might have a little bit more to it. It's a feasible and safe approach, but it still does need to be under fairly careful supervision, and it's still in its experimental ages. But this is one of the first studies, really, that is changing our management from what we thought was the right thing to do to what is scientifically proven to be a valid hypothesis. Then Shannon, thoughts?
So what it shows is we do harm by not introducing early. Also, I guess not all children need this to be under careful supervision. We don't want the take-home message, I'm sure Simon and I don't want the take-home message to be that every child who you want to introduce peanut to needs to be seen in a clinic. That's not the case. I guess if you had your child with really severe eczema, baby with really severe eczema, they may have comorbid food allergy due to sensitization through skin, and they may need more careful thought. But otherwise, if it's not a high-risk baby, I would introduce peanut really early. Even in the high-risk babies, we're introducing peanut early, even with skin prick tests well above 5 millimeters. But how to go about doing it, there's a lot of debate in the allergy community at the moment. Karen?
Can I just highlight a problem that we have down in practice is that we've been doing an infant feeding project with the La Leche League, and the breastfeeding is totally promoted for 6 months, exclusive breastfeeding. So when I'm trying to introduce this new thinking into weaning babies, I've got this other conflict really, and probably lots of others would be. There's such a big push for exclusive breastfeeding. till 6 months.
This doesn't replace breastfeeding.
Breastfeeding.
This
No,
is
it's the-
complementary weaning alongside
Yeah.
breastfeeding.
I think it's the exclusive till 6 months though, and we're saying you can start from 4 months
Yeah.
actually.
And I think mentioning the study, mentioning that there's significant potential for harm with delayed introduction, I think makes people sit up and think.
Yeah.
I think it's all about options as well.
Yeah.
That, you know, that's a particular viewpoint promoted, as we all did. But modern research is reflective on the fact that, you know, things do need to change, but they don't change fast. And it's like I say, it's giving parents choices, but evidence-based choices.
I also say we got it wrong until the study came out. And if you say we got it wrong, you're not saying you've got it wrong.
Yeah.
And we did.
Yeah.
We honestly did. So I think that also changes perspective.
What year did the LEAP study come out?
Last year.
Published, just last year.
Yeah, so
2015.
It's relatively new stuff, and of course it's a very much an ongoing study. And again, we'll come back to this, but once you've demonstrated tolerance to something that you were worried about, there is a commitment to keep that going. And historically, we saw kids, you know, who were shown to be tolerant, but such was the fear that their parents were still very reluctant to be giving those foods, even though they knew they'd had a hospital challenge and they were fine. And then sure enough, 5, 8, 10 years later, accidental exposure, and they've lost that tolerance again. So once you've demonstrated tolerance, we'll often say, and keep it going. You know, if it's peanut, make sure they get something with peanut in it 2 or 3 times a week. Doesn't have to be vast quantities, but keep that tolerance going. And this is what Mother Nature does.
Simon, I don't know what you see in your clinic, but we do sometimes see children who have been tolerant to food. Somebody's been desperate for a cure for their eczema, done a test, cut the food out. They've excluded the food for a few years, then tried it again and had anaphylaxis because they've failed to continue to maintain tolerance. And there was a child who was fish allergic, I think this was in Spain, where that scenario happened, who died, who'd previously tolerated fish, had been cut out because of a positive test, hadn't maintained tolerance, had anaphylaxis and died. So there are downsides too. Think about why you're doing a test, think about why you're suggesting exclusions. That's not to say it's not appropriate in some instances, of course it is, but